David, may I ask you to introduce our next speakers? We've enjoyed having our Guatemalan visitors here, and it's great that they're able to present CFAR as well.
Thanks. So I'm going to introduce, it's really a pleasure to welcome to Duke two collaborators from Guatemala who have been collaborating with us on a project on susceptibility to TB and HIV-infected patients. And they're actually going to talk about something different today. So Blanca Samayoa is a professor of microbiology at the University of San Carlos, which is Guatemala's national university. And she's also the director of research for the Clínica Familiar Luis Ángel García and the Asociacion de Salud Integral, which is the HIV clinic that was established in 1988 in Guatemala. It was Guatemala's first, or actually all of Central America's first HIV clinic, and they've done just fantastic work building this program in really creative ways in terms of funding and doing really fantastic research and patient care. And then presenting today is Dr. Eduardo Arathoon, who's the medical director of the clinic, and he did his medical degree in Guatemala and then trained in the United States at Wright State and then at Stanford, and then came back to Guatemala just as the HIV epidemic was starting, and is really responsible for an amazing HIV and AIDS clinic that you'll hear about. Okay, thanks.
Good morning. I'd like to thank CFAR for having me here, and especially to David Tobin and Jason Stout and all the wonderful people we've met here, and thank you for your hospitality. I'm going to talk to you about a success story, how we took this project from the lab into the clinic. And it's very seldom that you can see it in a very short time, and we were really lucky to see how we could do this. Histoplasmosis is a disease which is found in almost all over the world, especially in the Americas. And the mortality depends where you live, especially what your resources are. We know that in the USA it's around 12%, but in developing countries it's much higher than that. So we were very concerned about the mortality we were finding in our patients, and especially because WHO kept telling us that tuberculosis was the biggest cause of death in our patients, and we were finding something different. And actually, we had to convince them, or we're trying to convince them that this is not true. We haven't been able to do that. And so what we did is that in 2005, we approached CDC with this problem and asked them for help. And luckily, they said they would help for it. And we knew that there was a test that existed, which was actually produced by Joe Witt in the University of Indiana. And we wanted to have something like that and see if that would make a change. Typically, what we had was a microscopic identification of the organism. And we didn't even have much of silver stains. We were trying to look with PAS, which is not the best. And then our gold standard, of course, was culture. And we were having trouble culturing directly into microcell and Saburo media. And so it was with the advent of better improved blood cultures that we started to really find out that we had a lot of patients with histoplasmosis in Guatemala. So we know that immunodiffusion is less sensitive to complement fixation, and complement fixation also cross-react with and is very labor-intensive. So we needed really, there are other techniques like ELISA and Western blot, but we needed something simple that could be applied in the field in Guatemala. So we asked for a rapid, which was a lot to ask, but we asked for a rapid sensitive antigen detection assay that would overcome all these problems and would also decrease the time of diagnosis and reduce the mortality in the immunocompromised patients. So we knew that histoplasma, there was a test Joe Witt started in at the University of Indiana. And he then found the Miravista Labs and had this test. And over the time, the test had evolved into a much specific and sensitive test. But it had serious limitations. We couldn't send the specimens here, and each time we wanted to run a test, it was at $125, which for us was almost a think of. We couldn't afford that. And so we also knew that there was this lady in Colombia that also was working with another test. And we were lucky enough that we could get that lady working at CDC at the time we did this test. And our goal was to develop this antigen test, ELISA test, to use outside the USA for rapid diagnosis and to diagnose disseminated histoplasmosis. So, first of all, they went to a company and got an antibody, polyclonal antibody. They tested different compounds that came from the rabbits, and at the end they decided to use a specific one. And this was Christine Schiel who did that work. And so the advantages that we were looking for was to detect the active disease, to try to use a serum sample instead of drawing the blood from the patients, to have same-day results. This is very important to have same-day results because before it would take us about 14 to 19 days to get the results back for our patients. By the time we got the result, the patient already had died. So for us, it was very important to diminish that time. And also we tried to do quantitative testing as well. And this is to try to see if we could also have like a prognostic value in the test, which I think we obtained that too. So this is our clinic. It was established in 1988 after I left the Bay Area and I went to Guatemala, thinking that AIDS had to be in Guatemala as well, but we knew it was going to be all over the world by then. And so we dedicated to try to promote high-quality health services focused on HIV. And we went to Hospital General San Juan de Dios, which is the biggest teaching hospital in Guatemala City. And we established a clinic over there. At the beginning, everybody thought we were crazy because we were looking for something that didn't exist in the country. But sure enough, it was there, and we started working. And what we did with the assay was we asked CDC to help us with it, and we selected our population in about 18 months. People that had fever, 3 of these criteria, fever, pancytopenia, hepatosplenomegaly, weight loss, or any radiological evidence of disease, especially if it was miliary pattern. We always thought that miliary pattern was supposed to be tuberculosis. We know it's not true in Guatemala. The most common presentation is histoplasmosis. And also skin and mucosal lesions. This was important because in South America, we see a lot of skin and mucosal lesions, and we don't see it in Guatemala, but we put it in our criteria. We found something different. We found much more diarrhea than or GI involvement than skin lesions. But we recruited 212 patients, and they were enrolled in the study, and they were clinically defined as having histoplasmosis by the gold standard method. And so this is what we found in the patients. We found 65 patients with histoplasmosis, which was 30%. 17% of them were co-infected with tuberculosis, which was important too. And then this is probably histopathologic evidence of histoplasmosis. I don't think this is very specific. This basically was having granulomas seen in the microscope. And very seldom they could really see the organisms with the methods we were using. Also, these were the mycobacterium proven cultures, and this is what we found by staining the mycobacteria. We found 9 crypto patients. Of course, with this criteria, we missed most of the crypto patients. And we found 3 cocci patients as well, sorry. And we found one with pneumocystis. Pneumocystis is not very prevalent as it is over here in Central America. We don't know why. And also we found some parasitic infections and hepatitis, and there were 20 patients we really couldn't find what they had. So what they did is they put in the plates, they put the rabbit polyclonal antibodies, and then added the urine antigen, and then we made it glow, and this is how it was read here in the top. So this was a antigen capture assay format, which was quite simple to do over there. And we had a lot of questions from a talk we gave before about the specificity and sensitivity of the test. The sensitivity of the test for us was 81%, and 9 of 48 were false negatives. And these were normal people. I was one of the samples there. And this is the histoplasma patients, how they were found. This is the mycobacterium. This is other fungal diseases. And this is the parasitic diseases that we found. And when we compare it, the specificity was 95%. When we compare it with the other fungi, so what we found is that this is the histoplasma concentration of patients. We got serum from other places. We don't have Aspergillus, and we couldn't find them. So CDC provided the Aspergillus, the Candida, some of the cocci samples, and the cryptococcal samples as well. And Colombia, Angela Restrepo in Medellin provided the PBRAS samples. So there was some cross-reactivity with the PBRAS, but PBRAS, for reasons we don't know, unfortunately for us, is disappearing in Guatemala. And so, nevertheless, this was our cutoff, and as you can see, it performed quite well. The specificity was 90%. This is what I was telling you about the prognosis. You see, most of the levels were high at the beginning of the treatment, and then when we gave the treatment, which was basically amphotericin B deoxycholate and followed by itraconazole, most of the patients went down, and it gave us a prognostic factor, except for these 2 patients, which we don't know exactly what happened. We don't know if it was an interaction with itraconazole and the antiretroviral drugs, but they stayed up. And we also did complement fixation and with the immunodiffusion, and this is how they compared and different dilutions and the immunodiffusion. As we know, and you know as well, this is not very specific in our population, but our histoantigen did much better. So we have different comments. The histoplasma antigen capture ELISA is a sensitive and specific assay for the detection of disseminated histoplasmosis in immunocompromised patients. And antigenuria in histoplasmosis patients showed a marked decrease after the initiation of antifungal therapy. This assay may prove useful for monitoring patients' recovery in a clinical setting. And the H-capsulatum antigen capture ELISA is uncomplicated. It's quite easy to do. It requires few reagents. It can easily adapt to laboratories in areas of the world which are resource limited. And this technology was then transferred to Guatemala. And we are doing it for the past years, and about 5 years. And this rapid assay, we know is going to reduce the time of diagnosis, permitting much earlier therapy. And we didn't know exactly what the impact was going to be when we did that. And we hoped at the time to decrease the morbidity and the mortality. This is 1912, several years after implemented the test, and we sort of compared from 2008, like the mean mortality of histoplasmosis before and after the test. And it did save lives, and we were very lucky that the test really worked. And actually, it took a long time to do it, but nevertheless, I think it was worth it, and we're very happy that could do it. I would like to acknowledge all the people that worked with us in this test, especially David Warnock and Christine Morrison at the beginning. Dr. Warnock, I had to convince him to do the test. It was not easy. He was the head of, luckily he was the head of bioterrorism at the time, and that was how he got involved in it. He thought it was important to have a test. Mary Brandt helped us a lot. And then Lynette Benjamin, Chris Shield, she was the one who really did all the work in the laboratory. And then came Beatriz from Colombia to help us. Tom Chiller also it was involved. Tom Chiller had lived in Guatemala before, so he had soft spot there in his heart there for Guatemala, and he helped us a lot. And this is part of the team here. Dr. Samayoa is not there, so she was also part of the whole effort. And I also like to thank all the patients that helped. Interestingly enough, all this data that we have and we could characterize is being helping other people develop other tests as well. So now I think soon it's going to be a commercial test, urine commercial test, which will be much simpler, like a dip strip in the urine, and probably that will take only seconds to try to figure out what's going on with our patients. And this is how we founded the project, and of course, in our organization, we paid the salaries of all the people working on the project. Thank you very much.
Have you also done the test in people without HIV to try and determine if it has value there? Maybe a more challenging population because the prevalence of disseminated disease may be less frequent.
Yes, it works best in people with a high burden of disease, with a disseminated disease, definitely. And that's the same way Joe Witt's test works. It does work, depends if we're lucky enough to get them at that particular time where they have antigen going out in the urine. We have had a few outbreaks of people getting into caves in Guatemala. We have 110 species of bats in Guatemala, so caves are a big source of infection there. And we have had some people being positive or others being negative. And Joe Witt has also worked with some outbreaks. His test probably performs a little bit better with the outbreaks than ours. Ours probably perform better with HIV patients. Also, recently we had a gentleman who took a cruise to the Caribbean, a Guatemalan gentleman took a cruise to the Caribbean, went back to Guatemala, presented with fever without any cough or any other symptoms. And then the chest x-ray, we found a spot. We thought it was a cancer, but of course he had fever. And it was positive. And then we also, after this, we developed a PCR for history. We developed an in-house PCR in Guatemala, and we also could determine that the organism was in the tissue from the slides, pathology slides. So we have gone a little further on in our research in that respect.
Any other questions for Eduardo? Thank you. Eduardo.
Thank you very much.
So, Eduardo, that is an incredibly important topic. I was commenting to Kent that the first 3 patients that I saw at Duke in the late 1980s and early 1990s with disseminated histo were diagnosed at autopsy. So having a diagnostic test is incredibly important. So I have the opportunity of introducing the next program on our agenda, and that is the opportunity to hear from our young investigators regarding some of their very important research findings. So for the next hour and a half, we're going to have a poster session Please be very active at the poster session. Go and visit with the investigators, hear about their research, ask them questions, interact, network. That's an important function of the CFAR, is to see this networking process take place. We are going to come back promptly at 11:45 because we have 3 presentations from young investigators who are going to present here in this room. I did want to make a couple of comments with regard to the abstracts that were submitted. There were a total of 26 abstracts that were submitted. It included 4 CFAR cores, 7 different departments here at Duke, 2 institutes, and 2 centers. So CFAR is very proud of the opportunity to bring different people together. It includes 9 different U.S. university partners, 1 industry partner, and international partners in Kenya and South Africa, not including our Guatemalan colleagues who are here. So it's really fantastic to see this diversity of efforts. And for those of you who are abstract authors, be aware that there are prizes for the best oral presentation as well as the best poster presentation. So the judges will be interacting with you and wanting to learn more about your research. So we have refreshments. Make yourself comfortable in the poster area, and we will come back together at 11:45. Thank you.